Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to effectively treat their hearing loss so they can remain connected with friends and family and remain independent. I'm very passionate about hearing loss because I lost my brother Robbie twice, first to hearing loss from radiation to his brain tumor, and then when he passed away. I only care for ears. I'm the E of ENT. I have written a book called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. And I founded a hearing clinic of the same name, Listen Up Hearing Centers. If you want to learn more about that, go to listenuphearing.com. That's listenuphearing.com. I have a great guest today. It's Dr. Ron Leavitt. He's an audiologist, and he's published extensively in textbooks and scientific articles on hearing aids, ear mold acoustics, noise-induced hearing loss, hearing science, and assisted listening devices. He's has great experience. He received his doctorate in audiology from the Arizona School of Health Sciences. He served as a consultant to a bunch of organizations, including the United States Forest Service, the American Bar Association, and the Hearing Loss Association of America, which is a great organization. He served as a grant reviewer committee for the tinnitus research program at Oregon Health Science University. Before he went into private practice, he worked as an audiologist at the Good Samaritan Hospital and director of audiology clinic at Oregon State University. His passion is to ensure that all the hearing aids recommended in his practice meet rigorous standards and advanced scientific methods and technology. He's an expert on making sure your hearing aids are fit and on auditory rehabilitation. So he's a great guy to have on this podcast. Ron, thanks for coming on.
Mark, thank you for having me. It's a pleasure to be here, and I have a lot of respect for the work you've been doing.
Oh, I appreciate it very much. So, tell me a little bit about, you went into private practice, and I know you do, correct me if I'm wrong, a lot of auditory rehabilitation and work in that area, and kind of have a passion for the niche of making sure hearing aids are actually treating people's hearing loss. Is that correct?
Yes, as you know, we did an article where we looked at 179 different hearing aids on 93 patients from 24 facilities throughout Oregon, and found that using the guide that McCreary and his colleagues at Boys Town Institute had suggested, being within 5 dB of targeted important frequencies for understanding speech, only 2.7% of those hearing aids were fit anywhere near the individual's hearing loss, which gave us pause for concern.
Yeah, and so that is in Audiology Review, I believe. I've looked at it extensively. Just out of curiosity, how much attention has that gotten in terms of people coming to you? I'm afraid that it hasn't gotten as much as it probably should.
Well, it's been said that you can't prophesize in your own backyard, so. But our clinic's been there for 35 years, give or take, and we have some good rapport with the medical community because of our work at the hospital, and we also run a large consumer education group at the local hospital, which has gone on for 32 years, every second Thursday of the month. So we see a lot of people just at the hospital, and we get a lot of referrals through the medical system. But as far as the work we're doing in publication, that's much less known to the general public.
Sure. So tell me a little bit about this consumer education program that you've been doing for the past. That's intriguing. You're meeting once a month. I suspect it's not just a support group, it's an education group, right?
Exactly. And we use people who have had a lot of experience with hearing aids on the panel. Usually it's a panel discussion. But as far as consumer support goes, I think the biggest part of support in that group comes from seeing, for example, I have 9 audiology assistants who are lifelong hearing aid wearers. And they're very knowledgeable because they've got a pair of state-of-the-art hearing aids from all of the major manufacturers and can speak very knowledgeably personally and professionally about their experiences with those. And I think being able to see people who have become so successful, a number of them have gone on to be vocational rehabilitation counselors, doctors of audiology, speech pathologists. I think seeing that is a message to all people with hearing loss that it doesn't really have to be that life limiting if you really pay attention to good diagnostics and comprehensive rehabilitation.
And so when you talk about comprehensive rehabilitation, which is a topic that's really fascinating to me, what does that entail in your program, Ron? What do you guys do?
Okay, well, let me back up a bit then. It's funny. My professors are in two camps from University of Arizona, where I got my bachelor's and master's degree. Some of them are extensively into diagnostics. Some are extensively into rehabilitation. And those in diagnostics are always somewhat shocked the extent to which we do diagnostics. You mentioned in your book that asking people, how does that sound, is not a very good way to validate performance of a hearing aid. And I would argue, and you also point out that just a free screening test probably isn't looking at all the things we need to know before we move forward.
Sure.
The adage is you diagnose and then you treat. And if you don't really know about the diagnosis for sure, the treatment you're doing, I'll give you tinnitus as an example. It's estimated that there are millions of people in this country with tinnitus whose pure tone audiogram is perfectly normal.
Right.
There are people in this country whose listening skills are poor, but the pure tone audiogram is completely normal. So if all you're doing is some air and bone conduction testing and maybe some speech testing in quiet, you don't know much about this person. There's just so many other things we would do diagnostically speaking, not the least of which is measurement of uncomfortable listening levels, which is not really that common. Back in the 70s, it was David Pascoe in his doctoral dissertation estimated that you could get in the ballpark of uncomfortable listening levels about 70% of the time by just looking at the pure tone audiogram. Well, later on, Bentler and her colleagues at University of Iowa took a look at that in depth with, I want to say, 652 different ears, but don't quote me on that number. A lot of ears. And they found that you really couldn't come anywhere near that guess. So they discovered that a lot of hearing aids are not only underfit, which is what our article said about hearing aid fittings, but they're also overfit for loud sounds because nobody knows what the uncomfortable listening levels are. One of my other colleagues, Gus Mueller, put in an article where he dramatically changed the reported uncomfortable listening levels in the software and then asked the manufacturer's software to then set the hearing aids. And the measures that he gave in uncomfortable listening were very wide, in excess of 20 dB, yet the manufacturer's software fit the hearing aids exactly the same no matter what. So that is an area of great disinterest in the manufacturing side of hearing aid programming. And so, if people come to you and they say, everything's too loud, but I can't hear, that's a pretty accurate statement of what's really going on.
Yeah, no, I mean, you bring so many things to mind. I mean, one of the things I always tell to patients is, I say, well, I have my hearing aids and I hear really well. And I always ask them, well, how do you know what you don't hear? Right. And so it takes a little bit of a mindset to really think about that. But, to ask people to assess what they are not hearing is borderline absurdity. Right. I mean, and so the subject and one of the other things that I find interesting, Ron, is all of the surveys that people love. Right. Which, I think they are good because they lead to conversation. But, the fact that what is filled out in the survey does not correlate with the audiogram, meaning it doesn't predict what their hearing levels really are, is a fascinating thing. And I think the reason is we've allowed, or it's happened, that the sales and completing of the trial period are really some of the motivations for these types of things, right? So if you have a survey that shows you think you have an impactful hearing aid, you're more likely to get to the 90-day and a trial. And or if you have comfortable hearing and you hear less bad, you're more likely to get to the end of the 90-day trial. And I think this is a real tension in the hearing care industry.
I support exactly what you're saying, and I want to add to that a study by Humes in 2017 and his colleagues at Indiana University, and in 2019, where he had 3 groups. One of them got audiology best practice, rehabilitation, and real ear aided measures, and one group selected their hearing aids out of a box, more or less, and the third group wore placebo hearing aids that gave no amplification whatsoever.
That's amazing. I didn't know they had those.
Yep. So. And in this study, he discovered that at the end of the trial experimental period, he asked the placebo group, those who were getting no amplification whatsoever, would you be willing to buy these hearing aids? And one of the things in his findings was the price didn't matter. They had some people they told it would be $500 per instrument. Some they said $1,800 per instrument, but that had no relationship to their acceptance of the hearing aid. So the important thing I have to say about that is 36% of people with no measured cognitive problems, with an average of a master's degree and financial security, were willing to pay $1,800 per hearing aid for hearing aids that made no difference to their unaided hearing.
Wow. Well, that
36%.
speaks to the power of sales.
More than 1 in 3.
Perhaps. The power of sales, I think, and
yes.
suggestion. Yeah.
Well, as you know, placebo is a powerful thing.
Right.
Sugar pills have cured a lot of amazing things.
Yeah. And so swinging back, so in terms of the rehab you do, so and I agree 100%. I mean, one of the struggles I have, or not struggles, but repetitive conversations is people come in and they say, I want a cochlear implant. And I always say, well, there actually is a diagnostic process to get you there. I mean, what they really mean is I want to hear better. And I'm wondering if a cochlear implant is my option. The analogy I give to them, it's like walking into the cardiologist and saying, I want 4-vessel coronary artery bypass graft when you've only had an EKG, right? Like you get to that conclusion through multiple diagnostic evaluations, and I get they want to hear better. So I think the comprehensive diagnostic audiology beyond the standard audiogram, which many patients and professionals think is the bee's knees of assessments, is very important. But, I think the underspoken area is really the auditory rehabilitation. And that side is also very underappreciated. So what type of, what do you guys do in terms of that program?
In terms of rehabilitation?
Yeah.
Well, of course, we're looking at, there's a mounting body of evidence that getting a full correction for the individual's hearing loss based on real ear aided measures has a much greater cognitive benefit, protective benefit, than just wearing a hearing aid, period.
Right.
And 2 studies that really highlighted this point came out just this year. The earlier study was a meta-analysis of all studies that were relatively well done, where hearing aids were employed, and they looked at the reduction in risk ratio for dementia. And they reported in this meta-analysis that 18% of the population would show some risk reduction for dementia with that very active wearing a hearing aid. The second study was different. They insisted that everyone match an exact target with real ear verification. And they looked at those folks. And one group that had no risk for dementia didn't make any difference. But for the group that was already at high risk, social isolation, scores at the beginning. There's a variety of things. As I was saying, the group that was at high risk for dementia at the beginning of the study, they showed a 48% risk reduction ratio. So you got one group just wearing hearing aids, 19% risk ratio reduction. You got another group with meeting target on every single ear, 48%. So you just have to ask yourself now, do you want, as I was saying, so the very act of wearing hearing aids, 19% reduction in risk ratio for dementia. Fully corrected hearing aids for your hearing loss, 48% reduction. So my point being, of course, we start with real ear aided measures. After fairly extensive counseling about hearing aid benefits, we also have a book we produce each year based on our consumer education group I just talked about, where we talk about some of the features of hearing aids. And
the study showed that if the hearing aids met targets, there was a substantially increased risk of reduction of dementia. What were the numbers again?
48% versus 19% just wearing them.
Right. And so who did that study?
The first study was by Yeo, and I guess that's how you say it, Y-E-O et al., which is a group out of Singapore at the hospital there. The
Right.
second study is Frank Lin and his Achieve study and the group
Right.
at Johns Hopkins.
Right. And so you get people to meet targets. Do you do anything else about auditory training for them or to help them?
Yes. As hearing aids become more complex, the training becomes more extensive. For example, one of our assistants who's wearing hearing aids that are able to do fall detection and notify her that it's time to do something. And this is an interesting one, a change from any language to English through her hearing aids in real time.
Wow.
That to use that sort of technology, that's a lot of training. So she spends a tremendous amount of time with people just walking through. And that, by the way, is not technology for everyone. It's not for the faint of heart. If you're not really familiar with advanced features on your phone, this is not going to work well for you. But my point being, the more extensive the hearing aids capabilities, the more extensive our training has to be. We used to complain that, oh gosh, we're spending 20 minutes with people just getting the app downloaded and showing them how to pair to their hearing aids. That's now the least of our training, for folks that really want everything. So there's the extensive discussion about hearing aids beforehand, trying to demystify some of the, I think, outlandish statements made by manufacturers as to what to expect from the hearing aids.
The marketing stuff.
And then getting people, making sure they're really ready to do this. We're, like I said, we're not a good sales group. We don't at all push hearing aids. We want people to say to us, yeah, we really are ready to do this. And your book, by the way, has gotten a lot of positive feedback about that conversation within the family to help people get to that point. And I think that's a really important point. And Sergei Kochkin, a reviewer who is not an audiologist but a statistician, found that bringing family members to the evaluation tends to facilitate a lot more hearing aid uptake.
Yeah, well, I mean, it's having your loved one reaffirm that you actually have hearing loss and where you're having problems hearing. It's important.
You initially earlier said something about people don't know what they are not hearing until they hear it.
Right.
And I say that exact same thing a lot. And case in point, my audiology assistants, as I said, have gone on to get doctorates and master's degrees in various related disciplines. And one of them, most of them came with bad hearing aid fittings, not surprisingly, based on the article we did. In fact, some of them are in the data set of that article. But they came in with bad hearing aid fittings. And one of them was convinced she couldn't work. I can't do this. I'm too impaired. I stay home and I live with my parents because I can't hear well enough to work. Come to find out, the hearing aid fitting was dismal. So little by little, we turned it up until she met target, and then some. And because once she heard more, she wanted more.
Like,
and more.
I want, my brain wants more. Give me more.
My point being, she said to me one day, "Did you know?" And she was 24 years old at the time. "Did you know that hearing aids, that refrigerators make noise when they turn on?" 24 years, and she never knew that.
There was a humming in my house. I didn't know what it was, and then I figured out it was that. And I've had other patients in different circumstance. Somebody who had otosclerosis, which, as you know, is a progressive hearing loss, and he goes, "I forgot that when I tinkle in the toilet, it made noise," right? Because he hadn't heard it, right? Yes. So it's so funny what they forget, that right? You don't know what you don't hear. So as a question, so you will sometimes see these patients, their hearing aids are not doing what they want. Okay. As a practical matter, I mean, as I think about this, as you know, I mean, this is a big, deep conversation, but most services are bundled. And what I mean by that is people get the hearing aid with the associated services all in one fee, right? And so how do you handle people who have obtained hearing aids elsewhere who don't have targets but need their hearing aids adjusted? I mean, from a practice point of view, how do you handle that, or what do you guys do?
We do individually bill for all things. In fact, we pretty much use the price sheeting developed by Michael Valente at Washington University for that group in St. Louis. They have an extensive price list of everything they do and what it costs, unbundled, if you will. Right. And we just pretty much adopted it wholesale. And in some ways, we're going to have to change a couple of them because, as I said, as hearing aids become more complex in their operation and the things they can do, the amount of training that has to go on to get people to understand that, even those who are appropriate to that level of technology, has increased dramatically. So his initial charges were based on 2 years ago. And 2 years ago in our professions, both yours and mine, is eons ago. You know, when I think about how many things we've changed in just those 2 years.
Sure. Yeah.
No. But we unbundle, and we charge for all things like that. And I'll say this, since you ask about people who come from other facilities with bad hearing aid fittings, I would much rather start with a brand new person who's never had a hearing aid.
Right. They don't have any bias.
Than someone who's worn a dead hearing aid for 10 years, because those folks have developed a set of norms for what they hear with a hearing aid. And when you start introducing sound through these non-functional hearing aids, you have trouble that's really greater than you would typically have with just a newbie starting out.
Yeah, because their brain is accommodated, or their ability to tolerate sound is definitely going down. And your follow-up, what does that look like? In other words, how often do you see them, and et cetera?
For the first month, every week. If they're, because and this is consistent with the literature, when problems exist, they're usually there in the first few days. Right. And if you'll nail those down right off the bat, or at least address them, you know, we don't put people at a full correction on day one when they've never worn hearing aids.
Sure.
And as you know, some people come in with 60 dB flat audiograms who can hardly even get through the case history, but maintain they are hearing just fine at home. And for those folks, we have to work them into hearing again. And I agree with those researchers, and the name slips my mind right this minute, who maintain that there is a point of no return. If a set of circumstances in terms of brain shrinkage and changes in white and gray matter areas of the brain, as shown by MRIs and functional MRIs, have gone on too long, to pull them back into the world of hearing is a very difficult thing and may be too late.
Yeah, or frankly, maybe too labor intensive for people to actually do it in a realistic manner.
Yep.
And I know that's not what people necessarily want to hear, but there's only so many hours in the day and so many things that you can do. And then, so after a month, what do you see them at every 3 months, or what type of
then after the month, and that depends. If they're at a full correction and their aided speech and noise scores are normal, going to the Glick and Sharma article, we've reset the brain allocation to appropriate levels. In other words, using the auditory area. It depends on the results at the end of that month. If, in fact, they have normal scores on the speech and noise test with our hearing aids presented, with those speech and noise scores presented at a normal conversational loudness, I don't have too many grave concerns. There is some validity to that test that we use, in that we are keeping track of how many people can score like normal hearing people on this quick speech and noise test of Killian and colleagues. And I cannot think of an instance where those, and there's probably now 200 people, I haven't counted it up in a while, but we're approaching 200 people out of 6,000 in our medical database who can do this. And if they can do that, they rarely come back and say to me, I can't hear anything with these hearing aids. That's right. So I'm less concerned about those folks. And so then we might put them on a 1-year reevaluation schedule, because, as you know, some causes of hearing loss are much more rapidly progressive than others. And I like to know that rate of progression so that we can keep the hearing aids properly programmed, and we can counsel them appropriately regarding things they might be thinking about. You had mentioned cochlear implants.
Sure. People
coming for cochlear implants that really probably didn't need them. There's a group out of Cleveland Clinic, Sidlowski, King, and there were two other authors in that study. But what they found is that there were a number of people coming to the Cleveland Clinic for cochlear implants, and when had they not looked at the programming of their existing hearing aids, they would have been putting implants on all these people.
Sure.
But when they did and programmed them to a full correction, suddenly they weren't a candidate at all, to the magnitude of some people scoring upwards of 90% correct when they had the appropriate hearing aid fittings on speech tests in quiet, such I'm referring to the AZ Bio, for example.
Right. Well, what I tell my colleagues, I try to say to them, you're sending them to hear better. And then we do what I call a deconstruction of their hearing experience to figure out where that problem is. Yes. And so sometimes we don't, sometimes, and I think this is where there's a problem, because there are people in the cochlear implant industry. Well, we wait for them to be so far poor, right? But the reality is it's not off of the audiogram, it's off of the performance and noise. And so it's just a different measurement. And so you really can't tell from there are predictive things off of the audiogram, but as a general rule, we need to do more comprehensive evaluation. An audiogram, to me, that's why I use the heart analogy. It's like the EKG, right? And you need to do like a stress test and an angiogram to really figure out what you need done to your heart. And it's the same. We need to do further diagnostics. And so I think that that's really important. It's hard because I always say send them, right? And if we send back people who don't need cochlear implants, that's okay. They've explored another option and they're not a candidate. And so in the surgical literature, when everybody learns to be a surgeon, one of the things they oftentimes learn to cover in their first year is appendicitis. And so the teaching in appendicitis is if you don't take out some appendixes that are cold, meaning they aren't truly infected, then your suspicion is not high enough, because you should have 1 or 2 out of 100 that aren't. So then you got them all. Right. And I think it's the same for cochlear implants. You should send people for an evaluation of cochlear implants to the point where people are coming back as not candidates, because that means you've sent all of the candidates.
Absolutely. I see what you're saying. False positives and false negatives.
Yeah. And so you really want to get to that point, not, they have a corner audiogram and their discrimination's 10% in both ears, so now we should send them. It doesn't take a rocket scientist. It's really figuring out where are people really a candidate where they can hear better. And that's obviously an issue of controversy in terms of research in the literature. As I say, the cochlear implant companies are crawling up the audiogram and the hearing aid companies are going down the audiogram, and there's some overlap. For me, I'm not too worried about it, but obviously for them, it's a business issue. It's not just a clinical issue.
Yes, absolutely.
So where do you see things going in the next 10 years?
Well, I was asked this question before somewhere, and a couple of things came to mind. First of all, I came from, as you noted, Arizona. I was at University of Arizona as a professor for some years after I graduated, and was there for 7 years with my professors. And in those days, we had a lot of guest presenters. They would come from Mayo Clinic.
Sure.
They would come from the American National Standards Institute. They would come from the House Clinic. They would come from industry. We got quite a mixture of guest presenters. And in those days, we all kind of agreed that the best science is what we should be applying clinically.
Sure.
That's not so much the case now. There is a swath of professionals in my profession and yours that are of the opinion that people can go home and do it themselves pretty well, both diagnostically and rehabilitatively, if that's a word, in terms of rehabilitation. And I'm not of that school of thought.
I agree with you. I think the misnomer that drove that was that cost was an issue. And I think that if you look at the origins of that and you look at the adoption rate in places where hearing technology is free, it doesn't show a huge disparity between the paying, where people have to pay in the United States and people don't. I think, frankly, the biggest inhibitor of adoption of hearing aid technology is what I call poor peer experience, meaning because 97% of them aren't fit right, nobody says to their friend, like, this is the greatest thing since sliced bread, you should go get it. They all say, I hate my hearing aids. They'll say, I have one friend who returned them, another friend who doesn't wear them, and another friend who has them and doesn't hear any better. And it's because they're not adjusted and prescribed correctly. And I think that's the problem. But I think that there are some policymakers who did that. I tell people it's like DIY. Like, look, there are some people who can go to Home Depot, buy bricks, buy mortar, dig a trench, put a stem wall in, and build a very nice brick wall in the back of their yard. There are people who can do that. They have the skills. And so I saw a patient yesterday, both the son works in sound digital processing field. So do I think he could probably make it to the point where he could get a hearing aid tuned correctly for his father to be rehabilitated? You bet. I would not tell him no. But those people are exceptional. I could build a brick wall in my backyard. It would likely be a little crooked. It wouldn't look so pretty. The pointing wouldn't be right, et cetera, et cetera. And so we have to value the skills of the people. Just because you can do it yourself doesn't mean you should do it yourself. And so I look at it as an awareness thing, that it helps people become aware. And if people really want to get their hearing loss treated, then they should do it in tandem with somebody. But a lot of those people are never going to come to you. They are not people who would ever be your clientele because they don't value what you do. And as much as, we would like to do everything for free, there was a nun that my father knew, and her answer was, without profits, there is no charity, meaning you can't be charitable if you're not financially viable, and you and everybody needs to be financially viable. And so you need to derive a living, and a good living, for your skill set. And so if there are certain people who won't value that, they're not your potential clients. It's the ones that do. And so to me, I almost look at over the counter as Y2K for hearing aids. Like, we were all worried about the Y2K thing for computers, and the world was going to collapse, and then it happened, and it was like, wow, nothing really happened. I think over the counters have been kind of the same from my perspective.
Well, the American Speech Language Hearing Association released a survey of people who they thought might be candidates for over-the-counter hearing aids. And they discovered two things that are interesting. Number one, those over-the-counter hearing aids increased the uptake of hearing aids by 2 percentage points. Like you were referring to the European model where
Right.
they were free. Yeah. Price hasn't been as much as we thought it would be. And there was a second study that said it was only 1% uptake. That was the hearing in International Hearing Aid Standards, IHS, International Hearing Society. Thank you. And so it's on this 1-year anniversary in a few weeks now. It hasn't really made that big of a splash. And in the ASHA survey, they asked, well, are you going to be doing it in the future? And 4% said, we might think about it. So the potential market for this, I didn't think was going to be that great. I don't come across people who come in saying, gosh, I hope I can get hearing aids.
Nobody wants them. They just benefit from them.
Yeah.
Right. Well, I mean, if you want to talk about the marketplace, as you know, Bose was spearheaded the efforts to get over the counter. And I believe because they're in Massachusetts, they aligned with Elizabeth Warren. And that's one of the things that pushed it, Senator Warren, which is fine. But then subsequently, they got out of the market. And so it's kind of interesting that one of the companies that's considered kind of the experts in, sound and sound presentation then turned around and left the market, which frankly makes sense because Bose is a high-end product. And then there are no over-the-counter Bose speakers, so it's appealing to a higher level. And then the over-the-counter is the exact opposite. But still, it speaks, I think, of the marketplace. And you and I can revisit this in 3 years, and I suspect we would be quoting numbers of the same nature. Hopefully, it increases awareness. I mean, I would say the same as big box retailers. They have increased the awareness of people realizing that hearing aids can make a difference. That's kind of my take.
I'm with you on that. And to go back to your question about the future of audiology, I think that there will be more difference of opinion now going forward than there had been back in my days at University of Arizona, where we had guest presenters that we all liked the best science we had. There was no question as to whether it should be applied to its fullest extent.
If it doesn't work for you, then you don't want to apply it. Right. I mean, there are some inconveniences to it. And the other thing is unfortunately, as I watch your profession, it gets more and more fragmented, right? Subgrouped, subclassified, rather than speaking with a united voice. It's kind of becoming a more, I'll leave that up to the leadership, right, to figure that out. So.
Yes, not for us to decide here today.
No, or impact, quite frankly. So, and I think they're doing an earnest good job. It's a challenge. So, Ron, one of the questions I like to, what's your favorite sound?
Well, I'm a musician, so I would have to say it would be a Lloyd Loar mandolin of made in the 40s. The F model Gibson Loar model would be my favorite sound.
Wow. That's probably the most specific answer I've had in the almost 100 episodes of this podcast. So that's amazing. Ron, if people wanted to get a hold of you, how would they get a hold of you to learn more about you or talk to you more?
Our email, my personal email that we always use for publications is R-Leavitt. That's R-L-E like Edward, A-V like Victory, I-T-T like Thomas, 668@gmail.com. And that's really the best way. And both I check it daily, and as do my audiology assistants. So we keep an eye on that one pretty closely. People are certainly welcome to call, but that's a lot more hit and miss because of our busy clinic and the number of treatment rooms we have going simultaneously, et cetera.
And so the ability of other people to answer the phone when you call them back.
Yes.
That's one of the challenges. So for the listener, everybody, this is Dr. Ron Leavitt. He is an awesome audiologist. He's passionate about making sure that people's hearing technology actually meets targets or prescription and actually treats their hearing loss. And he's published extensively in the field. And obviously, as you can tell from the conversation, knows the literature. And it really is a great contributor to making the field a much better place. And so I really appreciate your efforts in this way, Ron, and hopefully the issues we're talking about get more attention.
And thank you for having me today. It's always a pleasure to see someone doing such good work.
Thanks for coming on. We really appreciate it.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.